Hello and welcome to this episode of the VJ Hemonc podcast, where we will be sharing some of the top updates in chronic lymphocytic leukemia from ASH 2025. These include key trial updates of novel BTK inhibitor monotherapy and combination approaches, BTK degraders, immunotherapy, and more. This podcast is part of the CLL channel on VJ Hemonc, which is supported by AstraZeneca, AbbVie, B1 Medicines, and Lilly. These supporters have no influence over the production of the content. This podcast is intended for healthcare professionals only. So to begin, Talha Munir will share analyses of the Phase III FLAIR trial that investigated MRD-guided treatment with ibrutinib and venetoclax in previously untreated CLL. This is followed by Matthew Davids, who will share further insights into fixed duration and MRD-adapted therapy in CLL.
It's my absolute pleasure to talk to you about the results of the FLAIR study. We presented a number of abstracts at FLAIR. One of the abstracts which I presented was the long-term follow-up data on ibrutinib plus rituximab comparison to FCR. And what we have presented in this data set that we've now got a median follow-up of 97 months, which is a very long follow-up on this study. And the ibrutinib in combination with rituximab had a superior progression-free survival as compared to FCR. So the median PFS for IR is reached at 112 months, which is in excess of 9 years, as compared to 80 months for FCR. This difference was really stark in unmutated IGHV GRIP patients. And again, we found an overall survival advantage for ibrutinib rituximab with 60 deaths in the IR arm as compared to 86 deaths in the FCR arm. And again, the difference is stark in patients with unmutated IGHV GRIP. In this follow-up, there was no new safety signals that we saw, but the strength of the study now is the very long follow-up. And what we find is that the ibrutinib, which is the first-in-class BTK inhibitor, especially in unmutated IGHV patients, is giving superior PFS and OS as compared to FCR and sets a benchmark for other second-generation BTK inhibitors. We also presented other abstracts at ASH, which were oral presentations. And one of the abstracts was looking at the MRD-guided approach with the combination of ibrutinib and venetoclax. And we looked at the genetic subtypes, which patients are benefiting from which combination of therapy. And what we looked at is the I plus V versus ibrutinib versus FCR. And we were able to assess all the analysis via next generation sequencing, as well as FISH analysis and somatic hypermutation for the IGHV as well. What we've seen in this data as well is that with I plus V, the benefit was stark in the unmutated IGHV group, and that was superior as compared to ibrutinib and ibrutinib rituximab arm, as well as FCR arm, whereas the difference was less palpable in patients with IGHV mutated disease. We also present for the first time the data on stereotyped receptor subset 2, and again in this group of patients, giving I plus V in an MRD defined way led to an improved outcomes as compared to ibrutinib given as continuous therapy or FCR. Again, for the ATM mutated or deleted patients, the I plus V patients are doing the best, and the outcomes are extremely good for those 70 patients who have been treated with I plus V on this arm of the study. So in total, what we found in all the subsets with the different genetic mutations, that the MRD-guided I plus V improved the progression and free survival and overall survival, especially in the ATM deleted or mutated group, stereotype subset 2, SF3B1, Notch1, and even TP53 mutated deleted group. And this again highlights the effectiveness of this MRD defined way in this study. We also presented some BTK mutation data in patients who are achieving ibrutinib on this therapy, and what we find in this analysis that there was no BTK resistant mutations found at baseline, but then 21% of the patients who were progressing on ibrutinib had a BTK mutation at either cysteine 481, T474, or L528, residues. And the treatment, these mutations were seen a few months before the patients developed progressive disease. So we went back and looked at all of this mutation data at different time points, and we were able to pick up these mutations beforehand. And in some patients, when the treatment was stopped before disease progression, the allelic burden of the BTK mutations had started to decrease already. We did not find any mutations in the I+V arm of the data. And finally, we also presented data on using UMRD4 as halfway treatment point for ibrutinib venetoclax. And we showed the ibrutinib relapse, the MRD relapse data for both FCR arm and I+V arm in this study. And what we find is that the dynamics of MRD relapse is different, but with FCR, we were able to show that once the patients are MRD negative, they take the IGHV unmutated patients are quicker to show MRD relapse and subsequent disease progression. Whereas when we look at the I+V patients, the unmutated patients are the one who benefit the most from the combination, and the unmutated IGHV patients continue to essentially have more MRD negativity with continuous therapy. But the recurrence of the MRD is also seen in this trial, and nearly at 4 years' time point, 72%, 1.1% of the unmutated IGHV patients had MRD relapse. And we also showed the data on whether these patients were able to get back into MRD negativity if we retreat these patients. So in short, we were able to show that the MRD recurrence can be used as a surrogate for progression-free survival. What we find in IGHV mutated patients, it takes an average of 6 years from MRD recurrence to progressive disease. It's especially in FCR patients. And in IGHV unmutated patients, it takes about average of 3 years from MRD recurrence to progressive disease. And hopefully this will highlight further advancement in treatment of CLL using MRD-guided approach.
So I would say that the most impactful abstract at this whole meeting was abstract number 1, which reported on the results of the CLL-17 trial, comparing continuous ibrutinib therapy as a monotherapy to time-limited venetoclax-based therapy, either in combination with ibrutinib or with obinutuzumab. And the study confirmed its primary endpoint, which was non-inferiority of the time-limited therapies compared to continuous ibrutinib monotherapy. All the patients are generally doing quite well in the study, 80% PFS at around 3 years, very high response rates, etc. But one of the challenges of the study is that it's only exploring the fixed duration regimens. So all patients get the same length of therapy, regardless of their genetic markers or their attainment of MRD. So there's a number of other studies looking at MRD-guided approaches for frontline CLL treatment. One of the important updates that we saw at this year's ASH meeting was the UK FLAIR study combining ibrutinib with venetoclax, but doing it as an MRD-guided therapy that was also time-limited. And really, their progression-free survival curves look quite impressive across a range of different prognostic marker subgroups. And they've done this through individualizing therapy through MRD guidance. And so it does raise the question of whether we're sort of leaving some efficacy on the table by only giving about 1 year of combination therapy, especially for patients with high genetic risk CLL like unmutated IGHV or even TP53 aberration. And many of the patients on the FLAIR study needed 3 or 4 years of ibrutinib plus venetoclax to attain undetectable MRD. And we're seeing now that translates into an excellent progression-free survival. So at this meeting, we don't have any head-to-head data comparing these two strategies of fixed duration versus MRD-guided therapy. But fortunately, there are now trials getting underway. For example, the CLL-18 study is comparing pirtobrutinib with venetoclax either as MRD-guided or fixed duration to a control arm of fixed duration venetoclax plus obinutuzumab. So we'll have to wait for a future ASH to get those results.
Next, Carsten Niemann discusses the long-term follow-up results from the GAIA CLL-13 trial on the efficacy of second-line treatment in CLL after venetoclax-based first-line treatment. He also mentions the CLL-17 trial.
I'm going to present on Monday here would be the long-term follow-up from the GAIA CLL-13 trial. You might not remember the GAIA CLL-13 trial. That's testing chemoimmunotherapy as compared to venetoclax rituximab and venetoclax obinutuzumab and venetoclax obinutuzumab ibrutinib. That's a 4-arm first-line trial. it showed superiority of the venetoclax obinutuzumab, in particular the triplet with venetoclax obinutuzumab ibrutinib, in terms of progression-free survival. But now we have also demonstrated that patients with CLL being treated in the frontline setting have such good outcomes that it might not that much be about what is the progression-free survival after the first-line treatment. We need to collect information on the long term, on the sequencing of different treatments for patients with CLL. And that's what we're presenting here. The outcome for 177 patients with CLL treated in the GAIA CLL-13 trial, now having received second-line treatment. And it's important to emphasize this is not randomized. It was based on the treating physician and the patient to decide what would be the next line treatment. And these 177 patients, they were treated in 4 different groups, more or less. One being BTK inhibitor based. That could be together with a CD20 monoclonal for some patients with the different additions. One group was venetoclax-based. Most of those received venetoclax together with a CD20 monoclonal. And then we had a small group receiving chemoimmunotherapy. Don't do that. They had a worse outcome than the others. And then the final group received venetoclax and a BTK inhibitor. So this means that we had 3 groups of patients either receiving a BTK inhibitor or 2 of the groups receiving a venetoclax-based regimen, either with a CD20 addition or with an addition of a BTK inhibitor. And these patients, all of them received venetoclax together with a CD20 monoclonal in the first line setting. And now we see that they have excellent outcomes from the time of second line treatment with a venetoclax-based regimen, with time-defined treatment used in the relapsed refractory setting after the patients had received venetoclax-based treatment in the frontline setting. And seeing that we at the moment have, say, 3 different options, at least in Europe, to treat patients in the frontline setting, being venetoclax together with a BTK inhibitor, either ibrutinib or acalabrutinib, venetoclax together with a CD20 monoclonal in terms of venetoclax obinutuzumab, or we could use an indefinite BTK inhibitor. And now from the CLL-17 trial being presented here at Sunday, we'll see that the 2 venetoclax-based time-defined treatments, either with venetoclax ibrutinib or venetoclax obinutuzumab, in non-inferior to a continuous BTK inhibitor in the frontline setting. At the same time, we can demonstrate in the GAIA CLL-13 trial from this long-term follow-up that it's also safe and very efficient to retreat with a venetoclax-based regimen, whether venetoclax with a CD20 monoclonal or venetoclax with a BTK inhibitor after first-line venetoclax-based treatment. Thus, now we are establishing that it's actually safe to treat with time-defined treatment, follow the patient at time of relapse, retreat with a new time-defined treatment. This gives us the concept of having to look for progression-free survival 2 or even 3, and demonstrating that it's feasible and safe, and probably reducing the toxicity for patients to treat them with time-defined treatment, breaks without treatment, and then retreatment with a time-defined treatment. And this gives us a perspective in CLL, focusing on the quality of life for patients with CLL and the importance for the patients to actually be off treatment. And when one of my colleagues interviewed patients' representatives from the Danish Cancer Society, a patient organization, they mentioned 2 things being really important for them in terms of what they focus on for treatment. One, they didn't want to be in the hospital, so they wanted to reduce the contacts. And I used to tell that I actually really enjoy and like my job at the hospital, but it seems my patients do not agree. So that's one focus. The other focus is that the patients are actually willing to accept quite significant toxicity from treatment, as long as they know it's for a defined period of time. But staying on treatment indefinitely, even with lower amounts of toxicities, but knowing that they'll never get rid of them because they have to stay on the medication, was a real issue for the patients that they wanted to avoid. So this emphasized that at this ASH meeting, we actually present both the data in the frontline setting, that time-defined treatment is non-inferior to continuous BTK inhibitor, and for the second-line treatment, that it's feasible to retreat with a time-defined treatment also in the second line.
Now we will move on to some trials investigating novel BTK inhibitors. Paolo Ghia will share findings from the Phase III BELLWAVE-010 study of nemtabrutinib plus venetoclax versus venetoclax plus rituximab in second-line relapse-refractory CLL. This is followed by Jennifer Woyach, who discusses Phase I results of rocbrutinib in relapse-refractory CLL.
The BELLWAVE-010 trial is a trial that is is divided in two phases, in two parts. The overall goal of the study is to compare nemtabrutinib, so a third-generation non-covalent BTK inhibitor, together with venetoclax, and compare it to the gold standard in the relapsed refractory setting, which is venetoclax plus rituximab. And before doing that, before enrolling patients in this phase of the study, there is another phase of the study where we assessed the tolerability of the combination. So, and also we try to find the correct dose of the combination. So nemtabrutinib plus venetoclax, nemtabrutinib, two different doses, 45 and 65 milligram. And we enrolled the patient and showed that indeed both doses of nemtabrutinib together with venetoclax are effective. We have 100% of overall response with the 45 milligram already, and 88% with the 65 milligram level. With the 65 milligram level, there has been 2 dose-limiting toxicity. One patient died also of a pneumonia that you might expect. Risk of infection is inherent to the fact that these patients are relapsed refractory with many previous line of therapy. So the first phase of the study is going to assess the final dose so that we can move to the randomized part between nemtabrutinib and venetoclax versus venetoclax plus rituximab. But the combination is feasible and is very effective with 100% of responses, 13% complete responses even in the 45 milligram.
OP-168, or rocbrutinib, is a novel Bruton's tyrosine kinase inhibitor. It is a very selective molecule, and in fact more selective than the other BTK inhibitors that are currently in clinical practice or clinical development. And it has a novel mechanism of action. So if BTK is wild type, the drug can bind covalently, similar to the way ibrutinib, acalabrutinib, and zanubrutinib all bind. However, if BTK is mutated at that binding site, like we see in resistance to the covalent BTK inhibitors, it can actually bind non-covalently or reversibly, similar to the way that drugs like pirtobrutinib or nemtabrutinib bind. And importantly, in the laboratory and in, I think, verified with early clinical data, we see that rocbrutinib is effective in the setting of resistance mutations that show up in patients taking non-covalent BTK inhibitors. So at ASH, we presented updates on the first-in-human Phase I clinical trial of rocbrutinib in patients with CLL. The entire study included other B-cell malignancies, but here we focused on the 42 patients with CLL that were treated. Various dose levels were tested up to 300 milligrams once a day, and no dose-limiting toxicities were identified. The drug was, in fact, very well tolerated due to its selectivity. Only one patient developed atrial fibrillation. There was one patient with a high-grade bleeding side effect associated with a fall. Otherwise, there are the typical things you see in patients with CLL, like low-grade cytopenias, infections, but no clear safety signals with this drug. In terms of efficacy, the overall response rate for patients who received at least 200 milligrams a day of the drug was over 70%. With a median follow-up of 30 months, the median progression-free survival is 28 months. So it looks very good in this highly refractory patient population. So we look forward to seeing larger clinical trials with rocbrutinib and combination studies, which are all in development.
Cheah speaks next on the Cadence 104 trial of the BTK degrader BGB-16673 in combination with other agents in relapse-refractory B-cell malignancies.
Cadence 104 is actually a trials in progress abstract, so we don't actually have any data to share at this meeting, but really it's an overview of a multi-cohort study in patients with relapsed and refractory B-cell malignancies, evaluating the BTK degrader BGB-16673 in combination with a range of partners. There's a sub-study involving zanubrutinib, sonrotoclax, which is the B1 novel BCL2 inhibitor, a combination with glofitamab, which is a CD20-CD3 bispecific antibody, and mosunetuzumab, which is another CD20-CD3 bispecific antibody. So there are varying cohorts across a range of different B-cell malignancy subtypes with dose escalation, and the trial is currently ongoing.
Finally, Barbara Eichhorst shares 2-year follow-up results from the EPCORE CLL-1 trial of epcoritamab monotherapy for Richter's transformation.
Yeah, the EPCORE CLL-1 study is a phase 2 trial evaluating the bispecific antibody directed against CD20 and CD3 in patients with Richter transformation. So there were patients allowed to enter when they had no prior treatment for their Richter transformation, as well as patients who had already prior treatment for the Richter transformation. And overall, what the study is showing that the median PFS was quite promising, in particular in the patients not being previously treated. However, we see how challenging it is to treat patients with previous Richter transformation. With respect to the safety profile in that study, there was, I think, only one CTC grade 3 ICANS and a few more of CTC grade 3 CRS, but with more corticosteroids being applied in Richter patients with Richter transformation, as well as for CLL, the potential additional dose we can use in the ramp-up period. It seems that also bispecifics are tolerated by the patients. And so it's a really, really interesting other option for patients with this difficult to treat disease.
Thank you for listening. Head over to vjhemonc.com to see our full coverage of ASH 2025. Be sure to follow us on X @VJHemonc and subscribe to our podcasts on Spotify, Apple, or Podbean. Until next time.